Hello and welcome to the CSF Rheumatology Author Interview Podcast. My name is Professor Peter Nash from the Griffith University in Brisbane. And today we're very, very fortunate to be joined by Professor Gerd Burmester from the Charité in Berlin. Welcome. Today we're going to discuss two recently published papers which analyse the safety of tofacitinib in psoriatic arthritis and hepatitis B in baricitinib trials with rheumatoid arthritis. So let's think about the first paper, which is an integrated study which analyses the safety of tofacitinib in psoriatic arthritis and compares it to real-world data. Gerd, can you tell us a little bit about how this study was put together and what you tried? What was the objective of the study?
Yeah, obviously, psoriatic arthritis is a very interesting disease. And first of all, let me thank you very much, Peter and CSF, for joining me today. And psoriatic arthritis obviously is a very important indication since we see quite a few patients with this disease. And it has some special features also in terms of safety. Usually patients are a little bit younger than rheumatoid arthritis, but also there are particular features like obesity, maybe more alcohol use. So it's a particularly interesting cohort to study. And so that's why we went ahead. We took two studies with tofacitinib called OPAL Broaden and OPAL Beyond, and one long-term extension study, OPAL Balance. And I think what is quite interesting, also we were able to look into a tofacitinib comparison cohort on a large data bank that had a lot of other patients with other diseases, so that we were able to compare the tofa data to, let's say, biologics and many others. And we were looking also into the placebo-controlled cohort, into this particular cohort, into all of them, and we're particularly interested in infections, obviously, in malignancies, in cardiovascular events, and obviously deaths.
And how long was the follow-up period with all these patients? How many patient years roughly were you able to track these patients out for?
Well, that depends on the various studies, and I think it's probably go back to the paper and for the individual cohorts, but we obtained data up to 12 months.
12 months. And I'm conscious of the EMA decision in the use of tofacitinib in particular. How has that affected its use, even in psoriatic arthritis in Germany?
Well, I must say we were a little bit surprised when we learned about the data with the 65 age bracket, which was derived from one study that is not yet published. So we will ultimately have to look into the data. Obviously, most patients with psoriatic arthritis are younger, and therefore the 65 age bracket has not been reached. So obviously, if a patient is 65 and beyond, is not a candidate for that particular treatment. If the patient is younger, it certainly is.
Okay. And what did you find in this study? It was an observational study. What were the results?
I think basically it comes down to the fact that the safety profile of tofacitinib was not really any different from what we know with other modern DMARDs like biologics, and so that was quite reassuring. You will see that in the paper quite in greater detail. What stuck out obviously was the herpes zoster signal that we know from most of the JAK inhibitors that we know, because this has also been shown for baricitinib and upadacitinib. So far we know the RA studies. This was also evident here for tofacitinib.
Did you see a dose response between 5 and 10 milligrams BD? My gastro colleagues are very concerned of the 10 milligram BD dose in ulcerative colitis.
Yeah, we see it in general for the JAK inhibitors. If you dose higher, it is likely that you have more herpes zoster signal. There will be one paper at EULAR from the Rabbit registry also confirming this higher zoster rate in RA patients in our German registry.
So the VTE issue is something we can't ignore. Was there any signal in these patients at either dose?
No, there was no signal in this particular study, as was in the general program of tofacitinib. Obviously, we are all aware of the one study that the EMA was referring to, where you saw a higher risk with 10 milligrams of tofacitinib. So therefore, my daily clinical practical advice is, if a patient is truly at higher risk for a VTE, and that is usually if they already had experienced such an event, I would be more hesitant to give a JAK inhibitor to this particular patient. But if it's, let's say, a regular patient without any significant risk factors, I would certainly be alerted that this might be an issue, but I would that would not really take me away from giving a JAK inhibitor to this particular.
And do you believe there's any difference between the JAKs as far as VTE is concerned, Gerd?
We will have to wait for the overall data of the filgotinib, which we will probably see, and some details will be presented at EULAR. And we will also have to look into tofacitinib when we have more Japanese data, so that we can look into the overall picture. But what we know from tofacitinib, baricitinib, and upadacitinib, that truly is a signal of roughly 3 to 4 events per 100 patient years. Obviously, there is a big debate now that you could potentially prevent herpes zoster and make it a non-issue if the vaccine against herpes zoster were available, and the non-live vaccine, which is quite effective. And we hope that this will be available to all the patients that will be in need of a JAK treatment.
Okay. And were there any response modifiers? Did background TNF exposure or steroids affect any of the safety signals, either infection or zoster? Was there any other messages from the safety side of the study?
I think basically we have a somewhat elevated risk with the biologics, which is not so strong in the psoriatic arthritis patients. Actually, we looked into many thousands of patients, also for TNF blocking agents and in previous papers, and there the infectious risk profile in psoriatic arthritis is very good compared to obviously rheumatoid arthritis and ulcerative colitis or Crohn's disease. Why is that so? Because in these diseases we have much more comorbidity. Rheumatoid arthritis patients are older, they frequently use co-medication with glucocorticoids, which is usually not done with psoriatic arthritis. So I see quite a few patients with psoriatic arthritis, and in my patients, basically, infectious issues are not really prevalent, and it is different in the other diseases.
Okay. And I'm not very familiar with the TruVen market scan. Can you just tell us what kind of a database that is from the US?
I think it's a useful American database where they look into patients with the psoriatic arthritis that they have identified based on these files. And then you can look into the characteristics of these patients and then can match the age, sex, and so on, and then have a reasonable comparison to your trial population. It will never be perfect, I must say, because the database may be somewhat older than the clinical trials. It takes a while to accrue all these data. But I think it's the best we can get in order to at least get an idea of the background safety profile.
Okay, so let's tick off the adverse events of interest, just really to see if PsA is different to rheumatoid, but the creatinine and the CK and the liver and the lipids and the neutrophils, do you see any signals or any differences from what you would expect from the class of JAKs?
Yeah, I think what we know is that usually it is more benign than rheumatoid arthritis, for instance, or the IBDs. I think you see less signals there, which is due to less co-medication. Would single out especially the glucocorticoids. the patients are younger. There is and sometimes the patient also more active. They are more able to do sports and other things. So in general, the safety profile in psoriatic arthritis is better compared to these other diseases.
So for the practicing clinician, any take-home messages from this safety study?
Well, the take-home message is, yes, in our data compared to an observational data compared to placebo and to biologics, it doesn't really have a different safety profile compared to these other drugs. You certainly have to watch out for herpes zoster, and otherwise we were not able to identify any new risk. Obviously, since the observation period was limited due to the nature of the trials, a longer term follow-up will be needed to provide additional safety information, and that is actually currently being done. As you also are aware, studies have been done with baricitinib, so that we will get another comparator as a JAK inhibitor, and then we will be able to look into both drugs and get even a better information about the safety profile of these drugs.
Okay, well, thank you very much. Can we just ask how you manage the vaccination issue in Germany? We can't get the kill vaccine. We can only get the live vaccine. But following your example, I did buy myself some Shingrix last time I was in Canada and had both doses. Thank you. What do you do with your patients? They're usually at a stage where their arthritis is flaring, they badly need a biologic, JAK inhibitor, normal, non-targeted synthetic biologic, and it's just at the wrong time to be having this vaccination discussion. How do you handle it in your clinic?
Well, I mean, you need to be pragmatic, and once the vaccine is there in the pharmacy, and obviously you always need to have 2 doses. That is an important message, because it doesn't make sense to vaccinate a patient with 1 dosage and 2 months later you learn nothing is available anymore. So I always secure 2 doses for these 2 injections, and then I'm very pragmatic. I just give it when I have it.
Okay, because we have to have this 3-week window to give the live vaccine, and it can be quite tricky when someone's bad that you're thinking about cessation.
Unfortunately, it's also
well, let's move on to, thank you so much. Let's move on to the second study, which is one of those things where these patients with hepatitis B exposure are excluded from most trials. Which are the hepatitis B patients that we need to look out for and think about either checking hepatitis B viral DNA or involving a hepatologist and a second drug, entecavir or lavimidine? Which are the Hep B patients we've got to be careful with?
Yeah. So first of all, in my daily clinical practice, I always do hepatitis B and C screening prior to using any biologic. I must say any, or any JAK inhibitor. It's just part of our program, along with a chest X-ray, the quantiferon test, and a careful monitoring of if there has been any previous TB exposure. And also reactivation of hepatitis B virus is a well-recognized complication in patients receiving DMARDs, and obviously it is particularly interesting in the Asian region where there is, in many countries, a higher prevalence of hepatitis B, but we don't know about the hepatitis B reactivation in patients on JAK inhibitors. That actually was the starting point of our trial to look into hepatitis B reactivation. In this case, we use baricitinib, which is a JAK inhibitor against JAK1 and 2. If I go to the methods, we also had 4 completed phase 3 trials and 1 ongoing long-term extension trials in which we had patients naive to DMARDs, non-responsive to DMARDs, or non-responsive primarily to TNF inhibitors. And the patients were all tested for hepatitis B virus surface antigen, which we call HBsAg, the core antibody, and the surface antibody. And the patients were excluded in the general program if they were, for obvious reasons, hepatitis surface antigen positive or hepatitis B core antibody positive, but negative for hepatitis surface antibodies, and hepatitis surface antibody positive, and if they had hepatitis B virus DNA recognizable there. So then hepatitis B virus DNA monitoring was performed in Japan for those patients who were C antibody positive and or hepatitis S antibody positive at screening, and then globally for all patients who had hepatitis B, C antibodies. And so what were the results? And I think the results are quite interesting, and I would say quite reassuring. So we had close to 3,000 patients that received at least one dosage. And out of these roughly 3,000 patients, a little bit more than 200 patients had a baseline serology suggestive of prior hepatitis B virus infection. They were hepatitis core antibody positive, and they received also a post-baseline DNA test. And of these 215 patients, roughly 15% were hepatitis B virus DNA positive at some point following treatment initiation, and only 8 of these patients, which is about 4%, had a single quantifiable result, which was set at 29 units per ml. And again, out of these 8 patients, only 4 met the definition of reactivation of hepatitis B, namely a DNA level above 100 units per milliliter. Of note, no patient developed clinical evidence of hepatitis, and in 5 of 8 patients, antiviral therapy was not used. So this is basically the study design, which is not easy to understand. Because it's a little bit complicated, but that's the nature of the matter of the serology of hepatitis B. But I think we did the best we could in this large patient population to look into this issue.
And so when would you involve a hepatologist? Which kind of patients are the alarm bells where involve a hepatologist and think about additional antiviral therapy?
Yeah, so I think in conclusion, and to follow your question, I think we must realize that hepatitis B virus reactivation can occur in these patients. Our data suggest that such patients I mentioned should be monitored for hepatitis B virus DNA during treatment, and they might be treated safely with the use of antiviral therapy as needed. And obviously here, hepatologist is necessary. I'm very lucky because the hepatologist is right across my office. I just leave my door, go into the next door, and there's the hepatologist. And I ask them, and they're usually, I must say, at least in our center, very helpful. So they are not say, oh, well, you're coming again. No, they're quite helpful. And though the hepatitis B reactivation was seen in some patients, reactivation was usually transient, and in our study did not account for any clinically relevant adverse events. And so still the issue is that screening for viral hepatitis should be performed in accordance with clinical guidelines before starting baricitinib treatment. So you should look into your local national guidelines. It's certainly different, let's say, in Japan compared to Germany or China. And in patients with serology suggestive of prior infection, the level of expression of hepatitis B virus DNA should be determined. And if you see that there is DNA, then, of course, a liver specialist should be consulted.
Sure. So we've always been taught surface antigen positive is a problem, but core antibody positive is also one to keep an eye on the DNA. And it's a little different from the tofacitinib study published from Taiwan, where they had a percentage of reactivation, but this message is the same. Be careful in those two groups, measure the viral DNA, and if there's any concern, get help and cover the patient. It's very reassuring they didn't have major reactivation episodes.
Absolutely. And then what the hepatologists tell us, if you would do an appropriate hepatitis B treatment, then you're not so much limited in your therapeutic options. And we have a number of patients with this problem, and they're doing fine.
So thank you very much. I appreciate your time on a busy Friday for you. We'd like to thank you for your presenting for us. This has been the CSF Author Interview podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, detailed slide sets are available in the publication section at cytokinesignaling.com. Please subscribe to the podcast in iTunes or wherever you get your podcasts from, and we'd welcome some feedback to let us know what you think, how to improve these podcasts. Thank you very much, Gerd, and all the best for the weekend.
Thank you very much, and all the best for you as well.